Welcome, dear friends. I'm Dr. Manjunath. Today, we'll discuss the under 5Es. Today, we're going to have more of a case-wise scenario. In our first case, we have a young boy who's about 3 years old. He has had wheezing episodes whenever he has had a viral infection. So, what do we need to do? In this case, we need to have a detailed history. We need to talk about the child, we need to take the history of the parents and the surroundings. So we'll start with the child. What are the questions we are supposed to ask? What would happen to this child in the in-between period? Was he coughing a lot? Did he have midnight wheezing episodes? Did he have runny nose as well? Would it worsen in the sleep or during the daytime? And we need to also ask regarding the exercise induced cough, like he takes a couple of stairs, would he get exhausted? Did he anytime have cough or wheezing episodes? Was he also having cough while laughing? These are the things which we need to ask about the child per se. We also should have the history regarding the dry skin or the symptoms suggestive of allergic conjunctivitis, and also history related to allergic rhinitis. So this is a comprehensive history and a quick history what we need to take from the parents regarding the boy. So once it's done, we should also elicit the history about the parents. Does any of the first degree relatives, do they have history suggestive of allergic rhinitis, asthma, dry skin, anything which suggests that there is aeroallergen sensitivity? These are the things what we need to ask whenever a child presents to us with wheezing during episode of viral infection. In our boy, Ramesh, he is about 3 years. He would come to OPDs whenever he had viral events. This boy did not have any history of dry skin, did not have any interval symptoms, no history suggestive of allergic rhinitis or allergic conjunctivitis. So what are we supposed to do for this boy? So we have, whenever a boy has come, we have taken a good history about the child, and at the same time we have taken the history of the parents. Now we need to have, where does he fall? Does he have low probability of asthma, some probability of asthma, or very high probability of asthma? These are things which we need to analyze. So here's a boy who has had symptoms only during viral infection. So he would fall in a category where he has very low probability of asthma. So what would be the line of treatment for this boy? As and when needed, short-acting beta-2 agonist. This is the only thing what he would need for the treatment of this disease. But in a situation when this boy is not responding, he has had multiple events and it is getting very severe, and he as well needs admission. At that time, a short course of inhaled corticosteroids can be considered for this boy. So this is the step 1 management, and Ramesh needs only short-acting beta agonist for him. We'll come to our second case. Now Dinesh, he is a boy who's around 4 years of age. He has had multiple events of wheezing. So in this boy, Dinesh, who comes to OPD with all the symptoms, in the sense like he has uncontrolled symptoms, and this boy also has interval symptoms, and this boy also has had multiple triggers for his wheezing episodes, in the sense like whenever he goes to play outside, he gets cough. Whenever there's an incense stick, there's for the agarbatti at home, he would cough. A small event of viral infection, he goes almost to the extent of hospitalization. Whenever he takes few flights of stairs, he would come with an episode of wheeze and a cough. So, this is a child who has a pretty high probability of asthma. So, our first line of treatment would be daily low dose inhaled corticosteroid. So, that's the only thing what this guy would need. So, with all the symptoms, the treatment modality is this. In a situation, parents say, no, 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 I don't want any inhaler. Why would I want to give inhalers to my child? And this parent also feels that inhalers are very bad, they're very addictive, and they also have too many side effects. What would you say as a treating physician? First thing, we would try and convince him, saying that this is a very simple medication, hardly has any side effects. All he needs to do is to take a couple of puffs of inhaler whenever the symptoms are present, and a maintenance treatment of low dose inhaled corticosteroids. So we need to try and convince the parents regarding that. Despite that, the parent says, no, no, I don't want it. At that time, the less preferred option would be a, say, Montelukast, like the leukotriene receptor antagonist. That is the next preferred option. So, and in the event of severe presentation, we might also have to consider inhaled corticosteroids. So this would be the line of management. So the preferred mode is a low dose inhaled corticosteroid. For any reason, if you are not able to start inhaled corticosteroid, the next best option is leukotriene receptor antagonist, that is the Montelukast, and as needed inhaled corticosteroids. And whenever there is any exacerbation, any flare up, at that time, short acting beta 2 agonist is still the treatment of choice. So, Ganesh is another boy who has already been diagnosed as childhood asthma, and he is not well controlled on low dose inhaled corticosteroids. You have done everything. You have taken a good history, you have started them on inhaled corticosteroids, and you've also seen how this boy takes inhalers. Is there any skipping of the drug? The method has been analyzed properly. Despite everything doing properly, his wheeze is still not under control. So the preferred method is to double the low dose inhaled corticosteroid. Well, that means if you are giving say 200 mics of budesonide, we might have to make it 400 micrograms. So this boy, this is the first line of treatment. For whatever reason, the parents are not agreeing to increase the dose, or we may not be able to do that. At that time, the less preferred option would be the low dose inhaled corticosteroid, a leukotriene receptor antagonist, that is the Montelukast, to be added for this case. As we discussed, the first line of treatment is inhaled corticosteroids, and the next preferred option is a Montelukast with inhaled corticosteroids. And whenever there are any flare-ups, any exacerbations, we might also have to consider adding a short-acting beta-2 agonist for this child. So this is the line of management for Ganesh. But unfortunately for Ganesh, he does not seem to have responded to any of those medications. We have checked the drug device and the dosage. Everything has been done appropriately. We have also considered adding a Montelukast, and despite that, he has not gotten better. So at that time, the preferred method would be to consider the specialist opinion. And the less preferred option is to have the leukotriene receptor agonist and an intermittent inhaled corticosteroids. This would be the line of management for this boy. I hope this discussion was very entertaining, at the same time very informative.
So put that in chat box. We will have a detailed discussion of all the cases, the symptoms, and we'll try to spread the message as much as possible. Thank you. Bye bye.